Hello everyone, my name is Brent Reed and I'm an associate professor here at the University of Maryland School of Pharmacy, and this is an encore presentation of a session that was given at the 2017 Heart Failure Society of America meeting given in Dallas, Texas. And the focus of this presentation is the roles of pharmacists in preventing heart failure readmissions. Now, as many of you probably already know, an unfortunate statistic about heart failure readmissions is that among patients who are discharged from the hospital after a heart failure exacerbation, about 1 in 4 of those will be readmitted within 30 days. And when you look on out to 6 months, about half of those patients will be readmitted. Now, recent meta-analyses have indicated that pharmacists can help reduce heart failure readmissions by at least 1/3. And when pharmacists are integrated as part of a multidisciplinary intervention, these reductions can actually exceed 50%. And so the focus of the rest of this presentation is just how pharmacists can do that by being integrated into the care of patients with heart failure. Now, a common paradigm in the management of heart failure and the prevention of heart failure readmissions is this idea that by the time patients become symptomatic, that it's very challenging to prevent a heart failure readmission. And in fact, in most cases, that's us reacting to those symptoms. And so, sort of one of the important transitions of thought is that if we could perhaps identify those patients who are at risk for a decompensation before they become symptomatic, perhaps we can proactively prevent that heart failure readmission. Now, from a pharmacist standpoint, I would contend that that proactive phase actually begins with the first admission, that the identifying ways to prevent a subsequent rehospitalization begins with an initial screening on that first hospitalization. And the reason why I say that is that the reasons why patients get admitted with heart failure is often complex and multifactorial, and pharmacists can help identify drug and disease-related causes and contributors to an initial heart failure admission. Most patients with heart failure have a number of comorbidities. The average is 5, and many of those patients are taking 6 or more chronic medications. And now I've listed here on the slide several common comorbidities, and many of these are independently managed by other providers who are treating those diseases according to their guidelines. So as you might imagine, this leads to a very complex medication list. Now, pharmacists, the primary way in which we can screen for some of those drug-related causes and contributors is through the process of medication reconciliation. Now, I know that's a term that's used very commonly, and unfortunately, the perception of medication reconciliation is that it's a comparison of 2 medication lists. So, does the home medication list match the hospital medication list? And while that certainly, meets the definition from a Joint Commission standpoint, really the goal of medication reconciliation is to identify medication-related problems. So not just asking, do these lists match, but asking, why is this patient taking this medication? And the reason why that's important is that up to 2/3 of admissions that are related to drug events are preventable, and nearly half of those involve cardiovascular medications. So medication reconciliation allows pharmacists to perform an in-depth assessment for errors, for adverse effects, for drug-drug interactions, and a point I'll come back to a little bit later, assessing for adherence and whether non-adherence to drugs or diet may have contributed to the heart failure admission. Now, there are data to indicate that pharmacists perform medication reconciliation with great accuracy, and for those of you that work with pharmacists, you know how focused we can be on the medication list, and I promise it's all for a good cause. Now, one of the other things that pharmacists are doing as part of this assessment is looking for polypharmacy. And so I have an example here from our own service on how this cascade can get out of control. So let's say, for example, you have a patient that has heart failure with preserved ejection fraction who maybe sees one of their providers for a gout flare, and they get started on a prednisone burst. Well, of course, that can worsen their blood pressure, and they might see another provider who sees that and treats that by either starting them on a new antihypertensive like amlodipine or increasing the dose of an existing antihypertensive. A well-known adverse effect of amlodipine is worsening edema, which is also common in HFpEF, and so perhaps that patient needs an increase in his or her dose of furosemide, or maybe it needs to get changed to twice daily. Well, now that patient is up at night going to the bathroom and they're hypokalemic, so they need a potassium supplement, and perhaps another provider starts them on trazodone to help them sleep. And so you can see how quickly this polypharmacy cascade can get out of control. So there's been a growing emphasis on the role of pharmacists in de-prescribing and helping address some of these effects of using drugs to treat the side effects of other drugs. Now, one of the things that pharmacists will tell you about medication reconciliation and one of the challenges is that it is a time and resource intensive process. And in fact, there was a study published in 2013 that indicated that it could be between 46 to 90 minutes to do an accurate, thorough medication reconciliation. And so if your service is already admitting 3 to 4 patients a day, and maybe rounds are already lasting 3 to 4 hours, you can imagine how difficult it might be for an individual pharmacist to be able to do this while managing all of their other clinical responsibilities. So to really make medication reconciliation work, you have to have a commitment not just from pharmacy, but also other members of the team to ensure that these activities can get done. So once we move past that sort of initial admission phase, there have been a number of studies to show how pharmacists can help optimize the drug therapy of patients with an acute decompensation of heart failure. And that's not really the focus of this presentation, and I'd really like to shift the emphasis from that to really the drug therapy changes that can be made as patients approach discharge. When it comes to the transitions of care research, a lot of the focus is placed on the discharge itself. But as many of you know, the discharge process starts several days before the actual discharge. A lot of those balls start rolling ahead of time. So pharmacists can be instrumental in helping identify ways to optimize drug therapy as that discharge date approaches. Now, I asked several of my colleagues, what are some of the interventions that come up frequently that are associated with reduced heart failure hospitalizations? And so I've listed here on the slide a few examples. So one might be increasing the doses of ACE inhibitors, ARBs, and other guideline-directed therapy in patients who have stable blood pressure and other clinical parameters, as doing so has been associated with lower rates of heart failure readmissions. Another one, and one that we've shown specifically at our institution, is that if you can transition a patient to their intended oral loop diuretic therapy prior to discharge, that can reduce their risk of being readmitted. And here we showed that if you watch them for a minimum of 24 hours on their intended discharge diuretic, that was associated with a six-fold decrease in their risk of heart failure readmission. One that came from one of my colleagues that doesn't work in advanced heart failure but still works in cardiology is that he's frequently reminding his team that in patients who have a reduced ejection fraction that you still can't rapidly up-titrate beta blockers when you're using them for other indications like atrial fibrillation or angina, as that could exacerbate heart failure. A strategy that we've used frequently at our institution is in patients who we're planning to make a transition to sacubitril valsartan, rather than washing them out of RAS inhibitors completely, we'll go ahead and convert them over to a dose equivalent ARB, so that they can be transitioned to sacubitril valsartan at their follow-up visit. And then lastly, ensuring that patients have the appropriate follow-up for any of the medications that might be initiated during the hospitalization. And so here I have an example for patients who are initiated on spironolactone, ensuring that they have the appropriate follow-up potassium monitoring to ensure that that therapy will be tolerated. Now, another thing that pharmacists are doing as patients approach discharge is performing patient education. Across several trials, that's been shown to reduce heart failure readmissions by over 40%. Now, critics will rightly point out that in one of the largest studies to look at this, the pill CVD trial, that did not impact readmissions. But I think one of the important misconceptions about that trial is that it didn't look at education versus no education. It really looked at individualized versus standardized education. And so you might imagine how difficult, particularly even in a study of that size, how challenging it would be to show an incremental benefit between those two groups. But I think one thing that we have learned from trials of that type is that a single education session at discharge is probably not likely to significantly reduce heart failure readmissions, and that perhaps a more longitudinal effort is really where the significant benefits lie. Another thing that pharmacists are doing that I alluded to previously is assessing for medication adherence, as that remains a major contributor to heart failure readmissions. And pharmacists can have significant effects on adherence rates. And in fact, studies have shown that pharmacists can improve adherence by up to 43%. Now, like discharge education, again, I think the benefits are greater with longitudinal efforts rather than just making sort of a single intervention as patients are about to be discharged. Now, some examples of how pharmacists can improve adherence as patients approach discharge. One would be simplifying those complex medication regimens, whether it's identifying less frequently dosed medications or getting rid of some of that unnecessary polypharmacy. Individualizing some of the education that patients might receive. So, for example, teaching patients how to adjust their loop diuretic therapy based on changes in their weight. Identifying ways to improve medication taking behavior, and that might be helping patients use pill boxes, maybe alerts on their mobile devices, or other ways to integrate medication taking into their normal daily routines. And then lastly, improving access to medications by identifying lower cost alternatives. And I want to spend a little bit more time talking about cost, since financial limitations continue to be a major barrier to the care of patients with heart failure. And in fact, in a study published in JAMA Internal Medicine, researchers showed that even within the same geographic area, that up to a 75-fold variability in cost of heart failure medications was observed. And that study just looked at price. It didn't even take into account the other many factors that make this more challenging because of the ways that our healthcare is paid for. So examples would be, whether or not the drugs were even on the patient's prescription drug plan formulary, or if they were, was a prior authorization required? And if so, what sort of hoops had to be jumped through to get that medication prior approved? Now, pharmacists can certainly assist with that, but I think a common misconception is that inpatient pharmacists are well positioned to help navigate those processes. And in fact, the unfortunate side is that inpatient pharmacists are the least able to assist with that process, as they really lack the tools and the access to the kinds of systems necessary to assist with that process. And really what it takes to help improve access from a cost and financial standpoint is having a committed outpatient or retail pharmacy team, is they're going to be able to run prescription claims, see what prior authorization requirements there are. And so, for example, there are a growing number of institutions who have used bedside delivery services to help improve access to medications. So having actually the discharge medications brought up to the patient's bedside before they go home, so they can leave with drug in hand. Now, if pharmacists, as we've talked about over the last several minutes, preventing heart failure readmission, a growing number of ambulatory care clinics have integrated pharmacists into the outpatient management of heart failure. And although the studies are smaller and fewer in number, they have shown substantial reductions in heart failure readmissions, even up to 78%. Now, there's two general models in which pharmacists are integrated into outpatient clinics. One is as an advanced practice provider, very similar to a nurse practitioner or a physician's assistant, where the pharmacist actually conducts a traditional clinic visit. This model is used by the VA and a few states where these kinds of activities are permitted by the state's practice acts. The other model that's used is the pharmacist is part of a multidisciplinary visit. So they are one of several providers that the patient would see during a single visit. And this is probably the more commonly used model because it's easier to implement. And the reason why is many states still don't recognize pharmacists as healthcare providers, and so they're unable to bill at the level that other providers would, and it's difficult for them to see patients individually rather than seeing them as part of a multidisciplinary team visit. And so that brings me to my last point, and that is the barriers that exist to further integration of pharmacists into these systems. The first is a regulatory barrier. So state regulations have generally limited the integration of pharmacists, and this is especially true in the ambulatory care setting. Now, we have made some headway, and although only 2 states still prohibit collaborative practice agreements, the states that do permit them, the services that pharmacists can provide vary significantly from state to state. The second barrier is a financial one. Although studies have indicated that pharmacists are associated with cost savings in excess of hundreds of thousands of dollars per year, unfortunately, healthcare administrators see cost savings and revenue generation as being very different things. And so, unfortunately, the widespread adoption of pharmacy services has been limited by the lack of a payment model. As I alluded to previously, federally, pharmacists are not recognized as health care providers, and so they're unable to bill at the level of physicians or other healthcare providers. And although a few states are now recognizing pharmacists as providers, that's still pretty limited. So one of my final point is, for those of you, whether you're a pharmacist or another member of the team, we could really use your help in advocating for regulatory, financial changes, legislative changes that would allow pharmacists to be better integrated into teams and taking care of these patients with heart failure, so that we can lead to some of the improvements as shown in the studies that I alluded to today. And so with that, I'll wrap up this presentation. And the last thing that I'd like to say is just a thank you to all the other members of the team that we work with, the physicians, nurses, nurse practitioners, physician's assistants, nutritionists, social workers, the list goes on and on. You all are often our greatest advocates and champions, and we look forward to continuing to work with you to improve the care of our patients with heart failure. Thank you.